Good afternoon. Thank you, Dr. Kosa. Thank you, Diabetes India. The topic is controversies. In this post-lunch session, Piglitazone is the controversy blown over. You must be wondering why this picture is there. It is because of the fact that this shows you the balancing act. Two sadhus are showing their balancing act, and this is what we clinicians need to do day in and day out while treating our patients. The balance has to be between science and art of medicine, a balance between heart and head of clinician, a balance between science and commercial aspect of various drugs. Wise man is one who grasps the new, it should be tried, but fool is he in haste who lays the old aside. Piglitazone, we have experience of more than a decade, anti-diabetic agent with probably one of the greatest number of data at the time it was introduced, more than 18 years of availability, more than 50,000 patients in clinical studies, and we do have long-term clinical trials to prove that this drug is there. More than 1 crore 50 lakh patient year of use is there with Piglitazone itself. One of the most powerful glucose lowering agents we have in our armamentarium. If you look at the oral drugs, hypoglycemia is the most talked about these days. Piglitazone has got least chances of hypoglycemia if you use it alone or in combination with metformin. Probably one of the only drug which has ability to modify the natural history of type 2 diabetes. There are data to favor that this glitazone alters the natural history. There is evidence for beta cell preservation. The benefits beyond that what I have enumerated, it is one of the strongest drug effect seen in prevention of diabetes in ACT-NOW study. It reduces diabetes incidence by 80% in 2.5 years. This trial was in fact stopped prematurely because of very strong data in favor of Piglitazone in pre-diabetic subjects. The only drug we have right now with us to treat insulin resistance, and everybody knows we Indians are different, that we have higher insulin resistance. It has got a very potent effect on A1C reduction. Not only potent, that is durable also, with low risk of hypoglycemia. It improves CV risk factors like HDL goes up, triglycerides go down, inflammation is reduced by use of glitazones, and there is reduction in incidence of microalbuminuria if you use Piglitazone. There is decrease in cardiovascular risk. The proactive secondary prevention of MI and stroke. This is the only drug which is shown to be effective in preventing stroke. So if you have a patient who is diabetic, had stroke, the only drug which is shown that it can prevent stroke is Piglitazone. It reduces CV risk in CKD patients. Everybody knows that majority of them, whether they are on hemodialysis or not, dies because of CV risk. So that is also reduced with use of Piglitazone. It improves liver cell damage in NASH or NAFLD. The cardioprotective effects of Piglitazones have been shown in various clinical trials. It improves endothelial function. It reduces intima media thickness by IVUS. It reduces thrombus mass on IVUS. Probably one of the few drugs to show that much of surrogate endpoint reduction of CV risk. It's a splendid drug. Multiple benefits that I enumerated are there, and We Indians as ethnic group have a very high insulin resistance, and this is the drug which reduces insulin resistance. Affordable. Our economy is that patient has to spend everything from the pocket. Majority of us are not, our patients or we ourselves are not covered under the health insurance, especially for outdoor treatment. Now, that much was about the good effects. The drug is born to be controversial. So controversies with Piglitazone, fluid retention, edema in heart failure, I will elaborate. Weight gain with Piglitazone is there, that is the fact to be acknowledged, I will elaborate. Bone demineralization and fractures are there with Piglitazone. Anemia is there, and bladder cancer. The most talked about and recent controversy about Piglitazone was bladder cancer. I'll take them one by one. Fluid retention, edema in heart failure. Let us see the facts about the fluid retention with Piglitazone. This is a meta-analysis, Lancet 2007. The hazard ratio is 1:30 as compared 1.30 as compared to non-exposed patients. The real concern is fluid retention and worsening of heart failure, which is much less common. I'll come to that. The proactive study clearly showed that heart failure and Piglitazone was without any consequence of subsequent prognosis. This heart failure with Piglitazone is not the heart failure that majority of diabetes have because of CAD or CVD. CHF in patients on Piglitazone might not carry the risk that is usually associated with other heart failures. Piglitazone is not at all a cardiotoxic drug. CHF on Pio is basically the fluid-related decompensation of previously existing systolic or diastolic dysfunction, which probably the clinician or we fail to understand at the time we initiate. We need to take care of that. Most cases could be avoided by following the contraindications for Piglitazone in patients with heart failure. Piglitazone, again I repeat, is not a cardiotoxic drug. There are benefits, and this is again BMJ 2007 benefits and harms of anti-diabetic drugs in patients with diabetes and heart failure. And these data clearly show you that Glitazone compared to other oral anti-diabetic drugs all cause mortality, and there is a clear favor for the drug rather than anything against the drug. Look at these data. No increase in mortality on TZD in patients with heart failure. This is patients who are diabetic or heart failure on Glitazone. Piglitazone beyond glucose control, I have already told you a number of things. It reduces arterial stiffness, it improves endothelial dysfunction, it reduces carotid intima media thickness, it reduces coronary arteriosclerosis, one of the very few oral drugs which has shown that much of benefits. Coming to weight gain with Piglitazone, weight gain is dose dependent. You can watch it, you can stop it. The stopper is there in your hand. This weight gain is without any metabolic consequences. With Glitazone, there is fluid and fat accumulation. It's more of redistribution and plus some fluid and fat accumulation. The visceral fat actually goes down and subcutaneous fat increases with Piglitazone. In spite of weight gain, there is reduction in waist circumference, so that means that the risk actually goes down with reduction in waist circumference, especially in Indian population. Rarely, this fluid accumulation can predispose to intraocular macular edema with visual consequences. We need to acknowledge it, we need to take care of it. Usually it requires only stopping the drug for reversal of weight gain. Bone demineralization and fractures, it is there in females more than 60 years of age. On the other hand, there is no increase in the amount of fracture among male patients, the clear meta-analysis shows the treatment with Piglitazone has been associated with a reduction in bone formation markers. There is preferential shift to the fat formation, fat cell formation than the bone cell formation. There is reduction in bone mineral density. Yes, one should be very cautious in females more than 60 years of age who have very high risk of fractures while using Piglitazone. The risk must be taken into account while looking at the benefits and risk ratio of each individual patient before prescribing Piglitazone. Bladder cancer, the recent of the controversies. This came into the light after this French meta-analysis, which clearly showed that although there is a low, this was initial phase of proactive study, 2.5-year follow-up. There is a rise in incidence as you keep on using from 12 months to 23 months to more than 23 months. The odd ratio goes up. Overall age, it is 1.22. That is one additional bladder cancer plus 10,620 patients. But this has not been seen in follow-up study. This is 10-year follow-up data, proactive study, and it says that small imbalance in bladder malignancy seen in double-blind period of proactive did not persist during 10-year follow-up of observation. On the contrary, there was slightly lower risk of bladder malignancy during follow-up among those patients who were initially randomized to receive Piglitazone compared to placebo. I hope you understand it is not possible to develop a malignancy, maybe bladder, within 2 years and then the risk goes down. It was something other than Piglitazone which caused it. A mean of 2.5-year follow-up on continuous exposure to Piglitazone during double-blind period of proactive study does not appear to be associated with increased risk of bladder malignancy over a long-term follow-up of 10 years. The DCGI, the most controversial body which regulates our country, it banned Piglitazone in June 2013 and the ban was revoked in July 2013. And these following recommendations are there: not to be used as first-line therapy for diabetes. The manufacturer should clearly mention a box warning in bold red colors, and this is the one. Coming to the balanced view right now, the results over the several recent retrospective analysis over a period of more than 2 decades in longer follow-up of proactive study clearly indicates that Piglitazone does not appear to increase the risk of bladder cancer more than any other anti-diabetic agents. I hope you understand that diabetics are at a higher risk of developing various malignancies. That too, bladder malignancy is higher in diabetics as compared to non-diabetics. A large population study in diabetics showed that incidence of liver, colon and lung cancer was 4 to 5 times lower in Piglitazone users as compared to non-users of Piglitazones. Liver, colon and lung cancer incidence is 4 to 5 times lower. The benefits offered by Piglitazone are far more than the alleged quote and unquote unalleged risk. It has been suggested that it would be ideal to use Piglitazones as and when indicated. When indicated, according to various guidelines, Piglitazone should preferably be used maybe at lower dose of 15 milligrams per day. Finally, the choice of Piglitazone in 2015. It may be preferable in patients with marked insulin resistance, and I give you the markers when to use Piglitazone. If you have 2 out of following 3 markers of insulin resistance, it predicts good and sustained HbA1c reduction, abdominal obesity, increased liver enzyme and low HDL. All these, any 2 out of these 3 is a marker. Piglitazone is useful in patients with insulin resistance early in the course of disease rather than late in an attempt to delay the use of insulin. All known risk factors that I enumerated must be considered in given patient. Pharmacovigilance is mandatory as with any other agent. Thank you very much, and as organizing chairman of RSSDI 2015, I invite all of you to be there at Lucknow. Please block your dates of 30th, 31st October and 1st of November. Nawabi Lucknowi hospitality with international standard of scientific material welcomes you. Thank you very much.